Thank you very much to the organizers and the organizing committee for the kind invitation, but also the challenge to give this lecture, because the title, New Frontiers in Primary Immunodeficiency and an Overview of Non-Classic PID, caused a little challenge, and I hope what I will cover will please you a little bit at least. These are my disclosures. So I was wondering when preparing this lecture, are we really thinking about new frontiers or maybe rather vanishing frontiers? I think I will try to show you that there's been, and already the previous speaker showed you, that there's an ever-growing diversity and a number of conditions and also an unexpected phenotypical diversity. But I will tell you also more about the phenocopies of primary immunodeficiency. So I don't know what, okay, thank you. Anyway, this slide is actually a repetition of what has been said before. It's actually the number of conditions and primary immunodeficiency, it's hard to keep up with. And every year, novel genetic defects are being described, and 65 novel have been added to the list since the publication in 2018 by the IUIS. What is also important is, of course, that, as highlighted before, different mutations in a single gene can show different modes of inheritance and thereby also even different pathogenesis or pathophysiology. And of course, the role of NGS cannot be neglected, with almost, let's say, 40% of all new diseases or diseases up till now described being unraveled by NGS. It's also not easy anymore to neglect a heterozygous variant in a result of, let's say, an NGS panel or in an exome sequencing result. So we have to be careful with neglecting heterozygous variants, because maybe in 2 years from here we will learn that this variant causes a disease in a different way. And so if we're not really linked to a lab or really putting to the test all of these variants, which is almost impossible to do, we are in trouble with recognizing all these various conditions. So yes, it has led us to precision medicine and also to precision treatment, but it poses enormous problems also to the physicians. Challenges, yes, but also many opportunities, of course. And then the unexpected phenotypic diversity. So what we've learned, we started off with a typical infection phenotype as described by Bruton in A gamma. And then we learned that actually more and more phenotypes evolved with malignancy, autoimmunity, autoinflammation, and allergy. So it's become rather medicine without frontiers in the field of primary immunodeficiency. Rather than being asked for an infectious disease patient, we are now being asked to see a patient in neurology with neuromyelitis, or we are asked to see a patient in gastroenterology. So we are across disciplines. So that makes it also more challenging to find a diagnosis. For instance, one of my favorite conditions of the time being is ADA2 deficiency. It started with the stroke phenotype and the hemorrhage, and already mentioning, of course, of some of the other phenotypes with aplastic anemia, ITP, and neutropenia. But now we also learn that there's lymphoproliferation, lymphoma, TLGL, and HLH involved in this condition. So more and more, it starts with a singular phenotype, and we learn that the phenotype can be so diverse that it's very easy to resolve from a clinical point of view what is really the condition of the patient. Another very interesting and recent set of papers is actually on mutations in CDC4/2, which is a Rho GTPase, plays an important role in the cytoskeleton dynamics and in cell division. And actually here is the gene and the representation of the protein in different regions. It started actually with a description of this particular mutation in a condition called Takeuchi-Kozaki syndrome, where patients have macrothrombocytopenia, and there was some mentioning of infection in the paper. And then recently in this beautiful paper by Martinelli in 2018, they went on to describe several groups of mutations in different regions, here in the nucleotide binding pockets, and in the CRIP domain here of this protein, where it was an entirely different phenotype. Yes, with dysmorphic features, but actually also with a feature of rhazopathy, more looking like a Noonan syndrome phenotype. And infections were mentioned actually in these two groups. And then recently in July, and then in September of this year, these two papers came out from the group of NIH and a group of Jordan Orange, showing that there's also autoinflammation involved in a different set of mutations at the C-terminal end of CDC42, where there's a neonatal onset of HLH and autoinflammation that can be cured by either anti-interferon gamma antibodies or in another paper by anti-TNF alpha. And we actually showed recently that also in the group 1 mutations, there can actually be autoinflammation. So we are learning more about the phenotype that had previously been described to just be dysmorphy and thrombocytopenia. So I would already say that these are non-classic PIDs because there's dysmorphy, there's cardiac defects, etc. And we are even evolving now to phenocopies of primary immunodeficiency. In the table at the IUIS classification, these are the diseases or the conditions that are classified as phenocopies, as already mentioned, associated with somatic mutations in FAS, but also in NRAS and KRAS activating mutations at the somatic level that give you a lymphoproliferative disease with an increased risk of myeloproliferation and leukemia. The NLRP3 mutations and the STAT5B mutations at autosomic level. And then here, of course, the phenotypes with autoantibodies that can really mimic part of the, for instance, CMC phenotype with anti-IL-17 antibodies. I think from a clinical point of view, there's many more phenocopies which are not in this table, but I will give you a few examples that annoyed me for a number of years. So this is actually a boy that was referred to me as having hyper-IgE syndrome ? He was 3-year-old when he came to me. He had non-consanguineous American parents, and he had severe eczema from birth and clinically relevant allergy to several food allergens. He had recurrent respiratory tract infections, and also at the CT scan, it wasn't really exactly perfect. He had recurrent phlegmone of the skin, but no candida. He was hyperlax, and he had a high palate. His hyper-IgE score was at 44, which was suspicious. We did, of course, sequencing of STAT3 in light of the high IgE levels there in the hyper-IgG and the high eosinophils. But the T helper 17s and the T follicular helper cells were actually normal. And of course, also the STAT3 sequencing didn't show any mutation. Our PID panel also actually didn't show any resolution to the question. We went on to whole exome sequencing, which at that time was really focused on finding genes that had to do with the immune system and not so much of the other human genetic conditions. And we couldn't find it, but I do everything to find a diagnosis. So if I don't find it, I give it to someone else, in this case, Anne Puel. And she found the diagnosis. She found the heterozygous variation in gap junction A1. And it's actually a very interesting phenotype here. So the mutation hasn't been described yet, so I have to say it's a variant until now. But at the same position, there's another variant reported that is pathogenic. And also the CAT score is quite high for the MSC score, and it's a private variant. So there's a lot to say for this, but we are still actually in the process of confirming this. So this disease is actually the disease in this boy by this gap junction protein alpha-1 mutation or variant is actually something that looks like the phenotype of the boy with erythrokeratodermia variabilis. It's a genodermatosis, and patients have hyperkeratosis and erythematous, eczematous patches. There's incomplete penetrance, and more importantly, and that's important for the future of the boy, is that there is arrhythmogenesis and cardiomyopathy, because these connexins actually play an important role in the conduction in the heart. I think so. This shows that genodermatoses are really important to recognize as a physician working in primary immunodeficiency. And here is another example of some kind of dermatosis. And this was a boy that I got to know during actually a spring school in Finland. This boy presented as having, to me and also to the physicians at that point, IPEX syndrome. He had neonatal onset dermatitis, ichthyosis-like, herpes simplex virus 1 came later on. He had recurrent skin infections, failure to thrive due to diarrhea. He had lymphocytic infiltration in the bowel, and then went on to develop cardiomyopathy later on. So he got FOXP3 sequencing, a gene panel, then an ichthyosis panel, and the diagnosis was not found until there was another panel of genodermatosis run, and this showed actually a mutation in the gene desmoplakin. And if you look at the literature on this very interesting syndrome, it's called severe dermatitis, multiple allergy, and metabolic wasting syndrome, or SAM syndrome. This is quite interesting because also in the blood there's immunological abnormalities with T helper 1, T helper 17 skewed T helper cells in the skin, and also T helper 17 skewing in the blood. Although this protein is not expressed, none of the two is expressed in the immune system. They are highly expressed in the skin, of course, and it gives rise to immunological changes. So this highlights, in my opinion, that it's important to also realize that the barrier function, if it's destroyed or disturbed, can give rise to immunological aberrant responses that lead to disease in the patient. Also with infections, and there's many of these examples that you know, and I think it's just important to realize the intrinsic role of the barrier also at the skin, but also in the intestinal epithelium, that it can really change the picture of a patient, and that it can really put you on a different leg or the wrong leg. Number C, for me, is also very much a phenotypical potential presentation of primary immunodeficiency, cystic fibrosis. And I actually trained first as a pediatric pulmonologist, so these cystic fibrosis patients are also very close to my heart, to be honest. And if we look at the presentation of cystic fibrosis, as you know, caused by allelic mutations in the CFTR gene, a chloride channel, these are the typical presentations, and it starts with lung infection. Staph aureus, and after that Pseudomonas aeruginosa, and then thereafter Burkholderia, etc., and also fungal infections. So it has many traits with primary immunodeficiency in common. And there was this daring, let's say, statement in the IUIS paper of 2018, where cystic fibrosis was classified as a neutrophil disorder in this table of the neutrophil disorders. And why is this? Why was CF there in this table? And I think many were unhappy with this classification, but maybe it makes some sense. So CFTR actually is also expressed in many immune cells next to those epithelial surfaces. So that's already an important feature. There's also an absolute B-cell site to cystic fibrosis. So many patients with CF do have hypogamma. Is it secondary? Is it primary? It's not well studied. We believe that it must be secondary, but I think it's important to know that you can be fooled by the presentation of a patient with less severe cystic fibrosis. There's absolutely something wrong with the CF neutrophils. They seem to have higher granule release and pycnocytosis, and they have also disturbed immunoregulatory function. There seems to be a high oxygen consumption, and they release more NETs, and they release more reactive oxygen species. So there is something to say for a disturbed neutrophil function in cystic fibrosis. And recently, there was also a beautiful paper on P10 deficiency and increased ROS production in neutrophils from cystic fibrosis patients. So atypical CF, especially with the less severe mutations in CFTR, can go undercover maybe as a common variable immunodeficiency. And this has also been shown already that if you don't do a sweat test straight ahead in a patient just presenting with recurrent sinusitis and with some mild immune defects, you might miss cystic fibrosis. So I think it's worth to realize that phenocopies do matter, and maybe it's primary, maybe it's secondary, but at least it needs our attention. Then metabolic syndromes. So we all know about folic acid defects and adenosine deaminase defects, of course, but I'm talking about something else here. The typical metabolic syndromes that we hardly ever hear of, but that have an interesting immunological side. So this is a patient that was referred to me at the age of 2.5 months with diabetes and hepatitis. She was thought to have a very strange or rare immunodeficiency. But what we found was actually homozygous mutation in the eukaryotic initiation of translation factor AK3 gene. So this is actually the cause of an autosomal recessive disorder, which is called the Walcott-Raleigh syndrome, with very early onset diabetes mellitus, epiphyseal dysplasia, pancreatic dysfunction, osteopenia, sometimes mental retardation, and hepatic and renal dysfunction, but also neutropenia, and very ill-explained neutropenia. And early fatal outcome mostly following flu-like disorder. And flu-like, I don't like the word too much, so when the patient first presented with this predicted flu-like disorder, we did PCRs for almost everything, and we actually found that she was not flu-like, but she was flu. She was having the real flu. And actually, we treated her, and her liver function normalized, but despite this, she had ataxia, and she developed cerebrolitis and atrophy. And from the age 2 on, I put her actually on sub-Q therapy because she had some subclass deficiency. And she actually did quite well despite a recurrent viral infection. And unfortunately, at the age of 6 years, she was admitted with yet another viral infection. And she deteriorated with liver failure and encephalopathy. And what we found was actually paraflu and herpes simplex virus type 1. But I fear that the treatment came too late and the poor baby died. So the question there was, is there a role for this protein in the antiviral defense? And to my surprise, actually, it's actually very highly expressed in the immune cells, if you look at bio-GPS at least. And more interestingly, if you look into the connectome, which I'm afraid I don't show here as a graphic, it's very close to type 1 interferon pathway in the connectome also. So I think this is a very rare disorder, but I think it deserves study if we are interested in flu in patients with metabolic disorders. So, are these secondary and primary defects? It's just an example. What about the glycosylation defects? The very interesting findings recently of the MECT1 deficiency and the glycosylation defects. What about the glycosylation disorders as such? They have an important impact on the immune function. Mitochondrial disorders and viral infections, also very interesting. Likewise, the lysosomal storage disorders. So I think many of these genes, if you look into it, if you're really targeting them, they have a true link or a close link with the immune genes. So I think there's a lot to learn there, and some of them really show themselves as phenocopies of primary immunodeficiency. So I think it's important that we keep an open mind and never take flu-like as flu-like. Just prove that it's really not flu or not another virus, and do your best to find this. So as a fourth way of thinking of non-classic, maybe we have to think in terms of affected cells, and this is absolutely not my idea. It's a very old adagium, so to speak. So protective immunity, it's not sufficient to have your immune cells. You need actually the entire organism. And what we all know is that the hepatocytes or the liver cells are extremely important in the production of complement factor, at least most of them, or APOL1, which plays a role in the defense against trypanosoma. But let's not forget the role of the keratinocytes also in EVER1 and EVER2. And that's the same is to say about the pulmonary and intestinal epithelium. And I want to also draw your attention on this very nice finding of the ALP deficiency, where you need actually the alkaline phosphatase of the brush border to kill or to cut, to hydrolyze the chain of the LPS in the bowel, from the bowel bacteria. So many cells in our body actually play an important role in the immune system that we may forget if we are too focused on the blood cells. So my conclusion, the field of PID and inborn errors of immunity, maybe we have to talk about new frontiers, but also maybe vanishing frontiers. And I really don't dare to say what is a classic PID, because I think primary immunodeficiency is everywhere, and I see it everywhere, much to the dislike of my clinical colleagues. And immune deficiency and immune dysregulation are intrinsic components of many other conditions. And the single rare PID diseases will, as already discussed before, further serve as a model for the less rare conditions, and probably also teach us about treatment ways to go. And with these borders vanishing, I think I took this from the latest Science magazine because I really like the slides. We shouldn't build bridges, we shouldn't build borders, but we should actually take coffees and teas together and discuss our fields of interest: primary immunodeficiency, metabolic diseases, pulmonology, and I think that is really what makes science and medicine great to do. Thank you to everybody who helped me and to the sponsoring of my little research lab. Thank you.